right?
Yep.
You can hear me. So my name's Celia Gregson. I'm going to talk a little bit about how we ran a particular study called the Reduce study. But just, I don't have any conflicts of interest. Just to set the scene, I mean, here are some countries. We have seen that public health expenditure just on health in general is ever increasing in almost all countries around the world. And when we look at the proportion of the spending that goes on fragility fractures, these data will be familiar to you. On the right-hand side, you can see that costs, the proportion of healthcare spending that is attributable to fragility fractures is increasing over time. But what you can also see is there's a lot of variation in how much individual countries are spending on fragility fracture care. And then within countries themselves, we have additional variation between the hospitals that are delivering that care. So this is a caterpillar plot from England and Wales showing variation in the proportion of patients getting prompt surgery for their hip fracture, and where each vertical line is a different hospital. So we wanted to understand what is it about certain organisations and how they deliver care that might explain some of this variation in patient outcomes or in the delivery of care. So I'm going to talk about the Reduce study. If you're more interested in it, then we've published the protocol paper here. But what we wanted to do is determine which hospital-level organisational factors potentially explain adverse patient outcomes post-hip fracture, including inpatient health costs in the whole year post-hip fracture, and identify areas on which potential cost-saving and national quality improvement initiatives could be focused. And then we wanted to use the learning from those analyses in order to inform the development of an implementation toolkit, a set of tools, that people like us in the audience can use to change and improve our practice. So we did a big record linkage study. We took lots of data from England and Wales. We put that together with the National Hip Fracture Database data for a 3-year period. And then contemporaneously, we extracted organisational metrics from 18 different reports and audits that are freely available. If you search hard enough on the internet, you can find them. And we extracted from those 231 organisational metrics. We brought that all together in a multi-level model. So we had data from 178,000 patients and 231 organisational variables that could be ascribed to each one of those individual patients. And we then looked at, using a multi-level model approach, we looked at the exposure that were these hospital-level organisational factors against a whole series of patient outcomes. I'm not going to talk through all of these outcomes today, but we were interested in, then for the toolkit, identifying the organisational factors independently associated with at least one patient outcome, associated with either a bed day saving or a cost saving, potentially also associated with other benefits, but not associated with a negative outcome. And I'm going to focus on hospital length of stay initially as a big cost driver. And this is hospital length of stay. This is the super spell length of stay. So this is acute plus the rehab within the NHS. And then I'm going to talk a little bit more about the costs over 1 year and health costs, which Petra introduced us to this morning. So the data set is across 172 hospitals, 178,000 people. You can see that the majority were managed in England, 23% over the age of 90, the majority female, majority coming in from their own home or sheltered housing before they'd broken their hip, and 37% freely mobile without a walking aid. So the first point to make is we saw a lot of variation between hospitals. So you can see the overall value. So if we look at length of stay, you can see overall, the mean length of stay is 21 days, 3 weeks in the NHS plus rehab. But you can see the standard deviation is 20, so it's highly skewed data. But some hospitals are managing to keep their patients in hospital on average about 12 days, and other hospitals on average about 42 days. So a lot of variation in that. Hang on. Here we are. So then we looked at the organisational factors associated with that super spell length of stay. We identified 22 organisational factors that were predictive of length of stay. So here, by way of example, you can see those hospitals that were managing to give nerve blocks preoperatively to at least 70% of their patient population saw on average a half-day shorter length of stay per patient. If we look at the proportion of so the hospitals that were able to provide orthogeriatric assessment to all of their patients, then those hospitals also saw on average a 1.5 day shorter length of stay per patient. And if hospitals had a protocol in place for intraoperative anesthetic care, then those hospitals saw on average a 1.2 day shorter length of stay. One of the biggest drivers of superspell length of stay was prompt mobilization. We've heard a lot about that. And in those hospitals that were able to mobilize promptly more than 90% of their caseload, then they saw on average a 2-day shorter length of stay per patient. So moving on to some of the other outcomes that we were interested in, as Petra already identified this morning, we saw on average, the average spend, hospital spend for a hip fracture patient is £14,642 per patient on average, but some hospitals are spending on average only £10,800 and others more than double that, £23,000, with a lot of variation across the country. So we identified in total 13 potentially modifiable organizational factors independently associated with cost and/or bed day savings, plus or minus other positive factors. And by far and away, the headline winner was the provision of weekend physiotherapy. So in those hospitals that were able to provide physiotherapy to their patients at the weekend, they saw on average £676 saving per patient in the year post-hip fracture. And you can see that all of these were associated with a per-patient cost saving. So orthogeriatric assessment of all patients within 72 hours saved money. Consultant orthogeriatrician attends clinical governance meetings on a monthly basis. A higher proportion of people admitted directly to an orthopedic ward promptly from the emergency department. Prompt post-operative mobilization, inpatient delirium assessment, and then when assessed, a lower prevalence of delirium, and all patients receiving a bone health assessment during admission. We also saw an additional 5 factors here that were associated with bed day savings, so having a hip fracture unit to which patients could actually be admitted, having a fracture liaison service in place, regularly disseminating your own hospital's national hip fracture audit data to your team and staff so they feel part of that process and understand the goals that you're headed towards, giving nerve blocks preoperatively, and giving a higher proportion of eligible patients a total hip replacement. We found a further 33 organizational factors, but these were the ones that we felt were the most potentially modifiable. Obviously, there are strengths and limitations to what I've shown you just so far. It's a really big data set, unique national linkage of data, but you can't infer causality. These are ecological analyses. So they may be that some of these things are markers of hospitals that are providing higher quality care. Data are not missing at random. The poorer quality service providers are more likely to have missing data. And we don't include social care costs, which Anthony's obviously explained is a large contributor to healthcare expenditure and social care expenditure. But we have identified multiple potentially modifiable organizational factors associated with important patient outcomes. And if causal, could be audited and amended in order to improve service provision. So 3 papers published, there's a couple more in the pipeline if you wanted to read more about that. But in parallel with this, we also ran a qualitative study of barriers and facilitators to service delivery, because not everything is metricized within those audits that I've described. So we wanted to understand the organizational processes that help or hinder the implementation of services. And we wanted to identify strategies that hospitals have used, particularly during the pandemic, to adapt and innovate care delivery. So we did one-to-one interviews with 40 service providers across a number of hospitals, and then we also kindly had access to anonymized peer review reports that the British Orthopaedic Association have run over the previous 8 years, and we were able to do a thematic analysis of those reports. So here is an example of a quote from an emergency department consultant who says, you know, our fascia iliaca block trolley is really good. We were having problems where our equipment was all over the place. We were taking an awful lot of time to find the stuff to do the blocks, to the extent that people just couldn't be bothered. We were incredibly busy in A&E, and the amount of time people were spending trying to find the stuff was an issue. So we found that we'd got a trolley that locks, has everything you'd need in it. You bring the trolley to the patient to give the block, and a number of nurse practitioners have competency packs now. We were hearing about the evidence in Norway about upskilling nurses to give blocks. So this is very much a locally driven quality improvement initiative. And so out of this qualitative study, we were able to make a series of recommendations based on our findings. So, for example, that when a patient hits the emergency department, promptly notifying the orthopedic, orthogeriatric and nursing staff that there's a new hip fracture that's come to the hospital, conducting training to routinely deliver nerve blocks in the emergency department by emergency staff with the equipment immediately available so that you can put that in efficiently, provide care for hip fracture patients in designated hip fracture wards, not outlying patients, agree that patients shouldn't be cancelled by any one single member of the MDT, that a patient who's already listed for theatre should only be cancelled in consultation, for example, with an anaesthetist and a surgeon, or a surgeon and a consultant geriatrician, for example. That trauma lists should be published early, ideally the night before, starting with the golden patient, prepared the day before so they can go straight to theatre at 8 when the theatres start, and include an extra list on the Friday so you're not going into the weekend with a backlog. Upskill nursing staff to be able to mobilise, particularly if you've got a shortage of physios. Provide specific hip fracture training for ward-based junior doctors who are always rotating and don't see the bigger picture in terms of where we're headed with these different quality improvement initiatives necessarily. And employ a discharge coordinator 7 days of the week in order for you to be able to get people out of hospital promptly. So we took this learning from the multi-level model and the qualitative study, and we brought that all together in this implementation toolkit. And if you scan the QR code, it'll take you straight to this website. And on this website are a series of tools, and they're all freely available, and you can go on and you can download them, and there's no copyright, help yourself, basically. But just to talk you through what's on there, we have a guide, how to do effective multidisciplinary team working. I mean, I appreciate that I'm already speaking to people who are very competent in doing MDT working, but one may work with colleagues who are not necessarily so skilled in that department. We have a tool about how to structure clinical governance meetings, what should be the standing agenda items on clinical governance meetings, what sorts of information you might want to be reviewing on a quarterly basis or a monthly basis. We've got a template for a hip fracture unit handbook, so this is where you can input your own local information about how your service is constructed into this handbook to make it bespoke for your hospital, and then you can give it to any new starters in your department, any junior doctors rotating around, nurse practitioners, etc. So it's a Word document, you can just download it and edit it as you wish. We have a service specification that kind of gives an outline of what a hip fracture service should look like and who does what and what the standards are that support those different roles within a hip fracture service. We have job planning kind of documents, so rather than everybody writing the same job plan for de novo for these different roles that we have within the hip fracture service, there's standard documentation there, so you can take the wording and you can input it into your own local hospital documentation, so saves having to write that from scratch. We have checklists of particular elements that came out of the quantitative analyses. Some of those are short-term checklists, things to try and achieve, and some of them are kind of more medium to longer-term checklists. And then we have an outlier audit tool, because we realized, particularly from the qualitative data, that this was an inequitable part of how we deliver care, putting patients on the wrong ward with the wrong teams. And this is a tool that might allow you to quantify that in a way to draw greater focus to their care. And then one of the bits I'm kind of most pleased with, I guess, and very much fed on the data that Petra presented, But we took those health economic models in order to generate this cost-benefit calculator. And just to talk, and there's a video that shows you how to use it if you want to watch the video. It's me talking for 20 minutes, but so the way it works is you take the Excel spreadsheet, you select your hospital, you select the evidence-based improvements you wish to make. So you might say, okay, I want to provide weekend physiotherapy and I want to provide nerve blocks to my population. So you then cost your service improvement. So you say, okay, I'm going to need a band X physio for this amount of FTE. So it'll calculate what that salary would be for you. And then you export your data. So you end up with a little table that says you will save this amount in your hospital and you need to expend this amount in order to do so. And then that information slots into this tool, which is a model business case, which gives you all of the text to support why it is that you need to make that investment in your particular trust. And so far, we've had, so up till September, we had 3,408 toolkit page views, which I was quite pleased about given the fact that we only have 172 hospitals. And 66 of those hospitals, of 172 hospitals, have already accessed the cost-benefit calculator. So it's up there for you if you're interested. So to conclude, I think that the methodology that we used in Reduce is applicable to other healthcare settings and other complex healthcare pathways where there are national audit data accessible and potential organisational metrics. Across England and Wales, we saw substantial unwarranted variation currently in how we're delivering hip fracture care, and we've identified multiple differences in how hospitals deliver that care that are associated with important patient outcomes, many of which are potentially modifiable. And then we've developed this freely available toolkit, which provides multiple practical approaches to hip fracture service teams and managers and clinical leads. And many of those tools could be adapted for other healthcare settings and other countries. So there's no copyright. So really just have a look. And if you want to adapt any of those tools, then just help yourself. And with that, I'd like to thank the Reduce study team, and the funders versus arthritis, and the Royal Osteoporosis Society who look after the website. So thank you.
We have time for questions. I mean, just a reminder, if you want, you can post the questions online as well.
May I ask a question?
Yes, you may.
I have had a problem that nobody knows what things cost. And not for real, too. We tried to calculate the first couple of days in the hospital versus the 7th day and got some interesting figures. But my main problem now, our main problem in our part of Norway, is that we have them for 4.2 days or something, the hip fracture patients. And then they go somewhere else where we can recommend but not decide. And they're there for a week or two, and then they go somewhere else, and then perhaps they go home, or perhaps to a 3rd or 4th place. We have been trying to get access to the community computer systems out there, and that's our really big challenge, to know where are they after 3 months or a year. Anybody struggling with the same?
Yeah, I mean, that's also an issue in the UK. I mean, at the time when we had this data set, most of the post-acute rehab care was provided by NHS providers. But in recent years, there has been increasing provision by private healthcare partners, and they're not obliged to submit their data to NHS data sets. So if you were to redo this study now, you would miss a lot of the data a lot of the rehab time spent within private institutions. I think that what we have done locally is a much smaller but much more detailed study where you identify a patient and you track them very carefully. And then you have to extrapolate that up to a larger population. And I think that at the moment that's all that we can do, unless you're able to link difficult to access data sets. But yeah, it's a problem in the UK. I don't know if you want to say
No,
the same
we
thing.
tried to do that with the NHFD several years ago, and there's just a secret length of stay hidden in care homes. Care homes that aren't, there's no incentive for them to discharge people or to get them home again. They're being paid to have them, and the longer they have them, the more money they get. And there is no way that the government can tell how much money they're spending on that or do anything about it. It's desperate. But yes, small samples, if we're following people up for the whole of the first year, then you can sort of map that. Or you can just nick the Trondheim results.
Yeah. Okay, we've got a question here.
Hi, thank you very much. This is fantastic, so thank you very much for the presentation. I'm Amy, I'm a consultant anaesthetist from the UK. I've just been looking at your checklists, and for the time to theatre, you've got that you want over 80% of your patients getting to theatre within 36 hours. We really struggle with that. We do most of the initiatives that you guys have got down there. What I want to know is, where do you get the 80% from when most of the NHFD isn't achieving anywhere near that at 80%? And for us, it's very much a capacity issue. So even though we're doing everything that you're saying to do, we just physically haven't got the capacity to get that volume of patients to theatre. And what would your comment be on that, which I think is what a lot of us in the UK are struggling with?
Yeah, I mean, I think that's a big problem and an increased problem since the pandemic. Where does the 80% threshold come from? So all of the thresholds that are in REDUCE come from the inflection of the splines within the multi-level model. So, so they are generated from the data themselves, where the relationship between the exposure and the outcome changes in pattern. So it is above 80% where one sees the cost differential, for example. So it comes from the model, and so there are enough trusts with enough, with some patients who they've obviously got to theatre within that time, to be able to populate that tail of the spline. But yeah, it's a smaller proportion than is general. Do you want to say something more general about the?
No, they're not predetermined standards.
No.
This is how the data behaved.
So I can go back to my managers and kind of go, right, if you give us more trauma sessions and more theatre slots and we get 80% through, then you will see a cost saving, is that correct?
That's correct. So you can use the tool in order to calculate for your trust how much you would potentially save by going from the proportion that you're getting to theatre in time now to your ideal proportion that you want to get to theatre.
That's great. I don't think there's any other business in the world where you have people banging on the door to work harder and to do more work, and we're desperate for more theatre time. We're just not given it by the managers. And I understand there's elective cases, there's conflicting priorities, but obviously as a trauma anaesthetist, I really want to get those neck ephemas through, and we're constantly told, no, you've got enough space, so that's really helpful. Thank you very much.
Yeah, I mean, I hear you. It's the same where we are. So, yeah.
Thank you.
Hi, thank you for the excellent tool. Can I ask about weekend physiotherapy? Is that for day one mobilization, or is that in general for all hip fracture patients?
That's for all admitted hip fractures. Yeah.
Yeah,
Not just day one.
so there's lots of pressure for people to get day ones up and then do nothing with them. And then you have the population of people who are in hospital who forget how to walk between Friday and Monday. And I hear that story every week. So I put my numbers into the cost calculator. It takes about 10 minutes to calculate out that I can save £150,000 a year by having weekend physiotherapy, and that's the business case that's in at the moment. It's very easy to use the tool.
We're also using this tool to improve our weekend physiotherapy provision currently in my hospital. Yeah.
Matt Costa, surgeon from the UK again. Just say massive congratulations, Celia, to the team. That website, for those of you who have not used the QR code, is in my favourites. We use it all the time. It's freely available, as Celia said. I can't commend it highly enough. Hugely powerful information that you can use to change practice in your trust. Just a quick comment for Fredo. You probably don't need to, certainly the UK data suggests you only need to follow patients for the first 4 months to find out where they settle. So most patients in the UK settle into one residence by about 4 months. We'll be able to present some data next year on exactly what happens to UK populations and associated costs out of hospital. So that'll be at the Istanbul meeting. September next year. For those of you who've not got it in your diaries, that will be freely available at that meeting. So, but shameless plug. It may be different in Norway, but certainly probably don't need longer term follow-up after that. Most people have landed where they're going to end up at that stage.
Thank you very much. We are spot on with time. Round of applause to our speakers.